Okay, welcome everyone. This is a deep dive specifically for you, our specialist, clinicians, and registered nurses listening in.
Hmm.
Today we're unpacking a source that lays out an admission protocol for cellulitis, and it's from the perspective of Dr. Gregory Weir, a vascular surgeon.
Right.
Our goal here is pretty straightforward. Boil this down to a concise, usable summary. Pull out the key steps.
Exactly, because having these clear, structured protocols, well, it's just essential in busy clinical settings, isn't it?
Absolutely.
So this dive, it's really about extracting that core roadmap from the source, from arrival right through to thinking about discharge.
Okay, so where does it kick off? Sounds like patient identity and welcome is right up front.
It is. The protocol really stresses confirming identity immediately using, multiple checks.
Like the hospital sticker, asking the patient directly,
Mhm.
maybe even an ID doc.
Precisely, all three, ideally. And it also highlights sort of creating a welcoming, reassuring feel for the patient and their family.
That first impression matters, yeah. Sets the tone.
Definitely. Safety and comfort right from the start. Then straight into initial investigations.
Okay. Blood tests. What's standard here?
Standard panel via Lancet Laboratory. Urea, creatinine, electrolytes, the basic kidney function check. Super important. A full blood count, obviously looking for signs of infection systemically, and C-reactive protein, your key inflammation marker.
Got it. UNEs, FBC, CRP, pretty standard infection workup.
Right. And the protocol is very clear that other tests, things like a chest x-ray or maybe duplex Doppler.
Or the more advanced imaging like MRA, CTA.
Yeah, exactly. Those are only done if the doctor specifically asks for them. They aren't routine admission orders.
Okay. Keeps it focused unless clinically indicated. Makes sense. What about medications on admission?
Okay, standard meds.
Mm-hmm.
Starts with Enoxaparin, 40 milligrams once daily. That's for DVT prophylaxis. Standard stuff for inpatients with limited mobility.
Right, preventative. And for pain.
Initial plan is tramadol plus paracetamol, 2 tablets 3 times a day.
Okay. And the antibiotic.
That's ertapenem, 1 gram stat dose right away. Then it's 1 gram once daily for 5 to 7 days.
And if that initial pain relief isn't enough?
There's an escalation option noted. Oxycodone naloxone, 105 milligrams twice daily.
Good to have that next step defined. Now, beyond meds, there are some really critical management points highlighted.
Absolutely crucial. Top of the list,
Yeah,
elevate the affected limb.
always.
Always.
All the time.
At all times. Essential for tackling that edema.
And the other big one, a major safety point.
Yes. Absolutely. Do not put a blood pressure cuff on the affected limb or perform venipuncture there.
Huge risk, right? Increasing pain, swelling, could mess with underlying issues.
Exactly. It's a non-negotiable in this protocol.
Yeah.
Then there's the general management piece.
Okay, what falls under that?
Vital signs check every 6 hours. So BP, heart rate, wrist rate, SATs, temperature, the usual monitoring, and a thorough clinical assessment. Really important to document allergies, iodine, antibiotics, whatever, and capture their current meds too.
Especially things like anticoagulants or antiplatelets, I imagine.
Definitely. Need that full picture. Also, assessing circulation is key. Palpating pulses, checking Doppler flow if you can, looking at the limb's color, temperature.
Basic vascular assessment.
Right. And ensuring patient comfort, get rid of any tight clothing. And hygiene, chlorhexidine shower if they can, or a sponge bath. Skin cleansing.
Okay, clear steps. What about activity levels? Are they just stuck in dead?
Initially, yes. Bed rest for the first 12 hours after admission.
Strict bed rests.
Pretty much. Avoid sitting bolt upright. They say only allow sitting at about 45 degrees for eating or drinking.
Okay, but then?
Then it changes. Once compression is on, and assuming the arterial flow is okay, the protocol actually encourages frequent walking.
Oh, interesting.
Yeah, short walks every hour or two.
Yeah.
And it specifically says discourage long periods of just sitting or standing still. Keep moving.
And it mentions smoking.
Actively discouraged.
Right.
Standard advice, but clearly stated.
Right. Now, compression. That sounds like a major part of this, given the vascular surgeon's perspective.
It is. Compression bandages are requested by the doctor, but only if arterial circulation is adequate. That's a prerequisite.
Makes sense.
And it mentions staff should be familiar with something called the Africa bandage system.
Okay, a specific technique.
Yes. Typically a multi-layer graduated system.
Yeah.
Good for edema, good for wound healing support. And once the edema settles and there's no open wound,
Then what?
an orthotist gets involved. They assess for the right compression hosiery. Usually it says class 2 below knee, cotton.
And a really important point here.
Critically important, anti-embolic stockings are never requested. explicitly stated.
Never. Very clear. Okay, what if there is an open wound with the cellulitis?
There's a specific wound care protocol outlined, step by step.
Let's hear it.
First, clean the skin around the wound, then clean the wound center. Use Prontosan for both.
Prontosan for cleansing and debridement. Okay.
Then, apply Inodine to the wound bed itself. That's the iodine dressing. But first...
Check for iodine allergy. Crucial.
Absolutely. If they're allergic, the protocol says use Acticoat or another silver dressing instead.
Got it. Silver as the alternative antimicrobial.
Right. And if the wound is producing a lot of exudate, a lot of fluid...
Needs more absorption.
Exactly. Apply a secondary absorptive dressing, like Misorb, right on top of the primary dressing, the Inodine or silver.
Okay, primary antimicrobial, secondary absorption if needed, then compression.
Then the compression bandages go on, again using that Africa bandage system. And graduated compression bandages should be used continuously until the wound is fully healed.
Wow, okay. Very structured wound care. Finally, discharge planning.
Yep, covered too. The key is making sure the patient gets their compression hosiery before they leave.
Don't send them home without it.
Right. The doctor provides a discharge protocol document, a script for pentoxify-line.
Often used for circulation issues.
And ongoing pain meds if needed. Plus, if they still need intensive wound care and bandages, a referral letter goes to a wound care specialist.
Seamless transition, hopefully.
That's the idea. And it mentions this protocol links to the general admission and blood pressure monitoring protocols too, so it's part of a bigger system.
Okay, so to recap briefly, this protocol really maps it out, doesn't it? From ID checks, initial labs, the specific drug regimen like ertapenem, those critical dunks like the BP cuff, limb elevation, then activity progression, the specific compression approach with the Africa system and class 2 hosiery, detailed wound care steps, and finally, setting up discharge properly with meds and referrals. It's quite a comprehensive guide from this source.
It really is. And what's striking is how this structured, step-by-step approach aims to standardize care for what can be a complex condition, especially when there are vascular concerns. Breaking it down like this potentially minimizes variations in practice and hopefully improves outcomes. So maybe the thought for you listening is, how does seeing such a detailed sequential protocol like this one make you think about your own practices? Are there specific elements here or just the structured approach itself that might inform or perhaps refine how you manage similar patients?